We're moving right along. We are going to be talking about all things cervical cancer, and I'm really excited. Yes, I'm going to say this about every panel and every speaker, but let me say that I am really excited about Dr. Ebony Hoskins because we've never met in person, but we followed each other socially on Twitter for a very long time. And I will say, just being a Black woman and seeing a Black physician that is specifically a gynecologic oncologist means just so much to me. And to also be able to have someone who's so actively engaged in the gyn-onc space, sharing in this experience from the clinical side is just wonderful. And you have her bio that's on our bio sheets. Read them. I don't know if we put them in the chat yet, but Morgan definitely put the bio and the agenda in the chat for anyone who's just joining. We had people registering in the wee hours of the night and this morning, so people may not have gotten all those things, but we'll make sure that you get them. So I'm going to allow Dr. Hoskins to share about herself, her work, her passion, and all things cervical cancer. So thank you so much, Dr. Hoskins, for joining us.
Oh, okay, great. Thank you so much for inviting me to come. It's a pleasure. I am Ebony Hoskins. I'm a GYN oncologist. I'm based out of Washington, D.C. And I've been practicing all 10 years. It's kind of gone fairly quickly. I'm sure you may or may not know that GYN oncologists are OBGYNs that are trained, subspecialty trained in oncology, GYN, of course. So we manage patients with cervical cancer, ovarian cancer, uterine cancer, all the GYN cancers. And so I think we'll go a little bit kind of what I will be talking about on today. Let's see if I can move this slide. So some of the outline, and you may or may not have gone through this, but we'll go through some basics. And I really like to present with discussion in the end. So feel free to write down any questions that you may have. I think we should just be, and I may not have all the answers. I tell people that all the time. I do not have all the answers, but I can look them up, or, we can at least discuss and go from there. So in terms of our outline today, we'll look briefly at cervical anatomy, some of the epidemiology. We need to talk about HPV because HPV is the primary cause for cervical cancer. There are very few that are not HPV related, but the emphasis today will be on the HPV related cervical cancers. Natural history of cervical dysplasia, or the pre-cancer before the invasive cervical cancer. Briefly, very briefly, about stage, treatment, and then we'll pivot to survivorship from a provider angle, not necessarily from a patient angle, but some thoughts I have, and hopefully we can have a discussion about that. So in terms of where the cervix is, it's what some people may say is the opening or the opening of the womb. And when we do a speculum exam, this is the picture that's kind of on the bottom. That's what we're seeing is the cervix. So this is the ectocervix. And then this little os is the entry into the endocervix. And as you can see here, the endocervix is quite longer. You can't see it. And so that's where some things, particularly adenocarcinomas, become an issue because they are not visible. And so that's still an issue in terms of the location. So this is what the cervix looks like. And this is kind of the anatomy: uterus, ovaries, fallopian tubes. Epidemiology. Thankfully, we have pap smears that could be preventative. And really, I think with the addition of HPV tests, in addition to the pap tests, we should hopefully see a decrease in terms of the number of patients that will be diagnosed. It is anticipated about 14,100 patients will be diagnosed with an invasive cervical cancer in 2022, and approximately 40 to 80 will succumb to disease. The average age of diagnosis is 50. And I think one thing that I would like to highlight is that 20% of new patients diagnosed with cervical cancer are greater than 65. Guess what? That's when the recommendation for discontinuing pap smears actually occurs. So I think that we have some room to work in terms of diagnosis and maybe catching disease early if there's a cancer there. So I realize that you're all muted, so it's kind of me talking, but do you know that which test decreased the incidence of cervical cancer in the United States? And the answer is a Pap test. So what actually is a Pap test? We used to call it a Pap smear. And the smear, this is kind of before we had improved technology, where we would, put the speculum in, look at the cervix and scrape the cells, and we would smear it really on a slide. And then they would look at the slide and kind of see there. Now we have the Pap test where we use a liquid, and this is what you may see your providers would put in terms of spatula and endocervical in there, and then they analyze it from there. So that's the Pap test. Now, and we'll talk about it, I think in my next slide, that at the same time of the Pap test that we can also evaluate for HPV. HPV. I pivoted right there, causes approximately 99% of cervical cancers. It can be used in conjunction with a Pap test or alone. And it tests for strains. And when the strains that we're looking for are not all strains, there's about 100 different types of HPV, but the tests are looking for the high risk. So when we say, high risk HPV positive, we're looking for the ones that are high risk meaning high risk for cancer development. It also, the HPV test can improve detection of endocervical cancers. So as you remember that picture I showed you earlier, when we were talking about cancers that are in the endocervix and we can't see that, we can't actually see the endocervix, the HPV test is really good and not really picking up pre-lesions, but in terms of being on the lookout, or your provider being on the lookout for things that can't be seen, in particular women who are menopausal. So this is, I think, the addition of Pap test with let me go back, that the standards change was probably about 8 years ago, where it recommended co-testing. Some providers were doing it earlier than that. And so this is fairly new in terms of they're recommended to do co-testing at the age of 30. It improves the sensitivity of detection of cervical dysplasia, or what I described early, cervical cancer. And there's all these different types of tests. Some tests only look at 3 different types of high-risk HPV. Some look at 2. So I would say, like in our practice, we do kind of a panel, and it looks at, I believe, like 13 different types. It doesn't specifically type them out, but you can order additional tests to type them. I don't want to go through a huge amount, and we've already talked about it. In terms of, I think, Tamika, you mentioned in some discussion before about no stigma here. I think there should not be any stigma, because HPV is the most common STD in the United States. It is responsible, as we discussed further, for virtually all cervical dysplasia, cervical cancer. Other things to keep in mind are vulval and vaginal cancers, anal cancers, and now we're learning more head and neck cancers as well. So, I think this is why we need to talk about it. Again, this talk is not talking about the vaccine, but I think the vaccine is a newer tool in terms of prevention that needs to be utilized. So in terms of statistics, about 80% of lifetime risk is approximately 80%. So a large amount of people that are walking around, there should not be any stigma. Maybe we've all had it. Some may have cleared, others not. In terms of the high risk HPV types is the ones that we need to detect. And then condoms are marginally effective. So in terms of the virus, I don't want to get too scientific, but I do want to go through a little bit of the physiology of HPV, cervical dysplasia, cervical cancer. So we'll go through that very briefly. We talked about the high risk types. I'm not going to go through all of that. The ones that is associated with adenocarcinomas are HPV 16. You can still, 18. And that's the reason why we always want to look at these HPV types. I have seen patients who had normal cytology, HPV positive, colposcopy on visual is negative, but an endocervical curettage detects an adenocarcinoma. So in terms of what brought that patient in an early, unfortunately did have a cancer, but she was diagnosed at an early stage, was the improvement with the HPV test. Yes, it was, I think, a devastating diagnosis because she had been going to her doctor and having, pap smears, like she said, but that HPV triggered her OBGYN to do a colposcopy and look further. And so I think, I'm not sure of the young lady who was speaking earlier about, educating people about HPV is very important. So again, we're not going through science. I'm not going to quiz you, but this is just a little picture that shows how the virus uncoats, enters the DNA. The DNA, the nucleus is where the DNA. So you may go back to the biology class. There's a cell, and inside the cell is the nucleus, and that just kind of replicates from there. And this is what we call, I stole this slide from SGO a long time ago. So Society of Gynecologic Oncology, just showing how the virus is shed, it assembles, kind of told you in the nucleus, it replicates, it makes the DNA, and then it starts to infect the basal cells. And then I'll just show you briefly the progression. So this is a picture of colposcopy, demonstrating CIN1, which is low-grade dysplasia. Typically, you'll see it with like a low-risk HPV, acetyl white there. This kind of correlates on how these cells look. These cells look a lot different than the normal cells. And then as we progress to the next slide, we have CIN2-3. The cervix has some mosaicism, some abnormal vessels, this acetyl white, but the nucleus and then the abnormalities. So when they say CIN2, it's kind of halfway of what we call the basement membrane. And then this other picture, it just shows higher grade dysplasia. And what makes a cancer is when all of these cells are abnormal, and then they invade what we call this, there's like a basement membrane and it invades. That's what makes a cancer different from a quote pre-cancer. I don't like using that word because only people hear as cancer, but I do it because that's how I think people understand. So what happens if CIN2 or 3 is not, addressed, then you get invasion. And again, this is when you see cells that are invading the actual stroma. Remember that basement membrane I talked about? You can't see it anymore because that's invaded. So this is just a picture. It's hard to see, but kind of, again, what a picture would look like with an invasive carcinoma. Now that's the speculum, when we do a colposcopy or a speculum exam. Briefly, so squamous cell is what I showed you in the beginning, showing you the outside or the ectocervix. Those are typically squamous cell carcinomas, and then adenocarcinomas of the cervix are found usually in the glandular cells, and they tend to be in the actual canal and then the endocervix. I find that women who are, say, postmenopausal or those are women who are more at risk because it actually is in the actual endocervix, that area that's most susceptible, if you will. Okay, so briefly, we're getting there because I want to have more discussion than me talking. Going through stages very briefly. Stage 1 basically means the disease is confined to the cervix. Stage 2, disease is within the parametria. Stage 3 could be the pelvic sidewall or lymph nodes. And stage 4 is distant metastases. So these just kind of break down like stage 1A1. They break down to all these, and they've actually changed the staging, I believe, last in 2018. So sometimes, even though we're doing this every day, I constantly kind of have to go back, because even as I've finished residency from fellowship, the staging has changed. But anyway, these just kind of go like a patient who may have a very, very small cervical cancer can be treated with a simple hysterectomy or a cone if it's fertility sparing. Patients who have a little bit larger than a 1A1 can be treated with radical hysterectomy, which means, I think I have a picture on the next one. I got this from the internet, it's not from me, but basically uterus. They took the ovaries, which is a discussion we could talk about later, but uterus, fallopian tubes, ovaries, and this is the parametria. So the parametria is the tissue surrounding the cervix. And so we want to make sure we get a negative margin And then we usually get a portion of the vagina, the top part of the vagina, and a radical hysterectomy specimen. So the state patients with stage 1B, again, the disease is confined to the cervix, but pending what the findings are, the character of the tumor, on whether we offer surgery versus chemoradiation. Again, that's kind of out of this context of our talk today. And if you have any more specific questions, I'm happy to talk with you or talk about it. But in terms of treatment, can be surgical or chemoradiation, pending on the characteristics. And then stage 2A to 4A typically are considered locally advanced cervical cancer. It used to be that we would treat it with radiation alone. Again, thank God that we are progressing in terms of our advancements. And so you can even see in 1999, the NIH released a consensus guidelines that found that use of cisplatin with concurrent radiation improves survival dramatically. So we had decreased risk of death from cervical cancer, approximately 30 to 50%. And that's huge. So now anyone who has locally advanced cervical cancer will be offered cisplatin in conjunction with external beam radiation, vaginal brachytherapy. So now I'm pivoting a little bit to survivorship. And I think that you have other talks about survivorship, but this is in survivorship in terms of what your provider could provide, in terms of how you could advocate for yourself or your loved one. And then it's kind of our shortcomings in terms of the medical community. I think that we don't do a great job of it, but I think that's why we're talking today. So survivorship, the question that I hear quite frequently from my patients are, I have like this little timer on. Anyway, for my patients are, will the cancer come back? What are the signs of recurrence? How can I maintain my health? What should I be doing? I'm seeing you less. So, it's I think even more vulnerable time, even after completion. We should, we don't see any evidence of disease. Now what's next? And those are questions that I frequently encounter. And so there are numerous governing bodies who think that we need to have survivorship plans, which I agree that we do. And the purpose of survivorship plans are to increase the number of cancer survivors, because survivors feel lost in translation in terms of post-treatment care, and to coordinate care with gynecologic oncologists and specialists. Sorry, I just don't want that to go off anymore. And so that's the purpose of a survivorship plan. And essential components of a survivorship plan include, and I think it's good for the patient to have this, and I'll tell you why, but in terms of a treatment summary, so knowing, kind of what treatment was done, when it was complete, when surveillance occurred, how often surveillance should occur. And also the goal is to prevent and detect any new cancers. Coordination of care with primary care doctors and specialists, promote overall health, because there are other medical issues besides cancer that we need to be on the lookout for. Management of persistent and late effects of treatment. So those are kind of components of a survivorship plan. And these are all coming from like Live Strong Essential Elements and the Institute of Medicine Cancer Patient to Patient Survivor. Optional elements of a survivorship plan are psychosocial assessment, comprehensive medical assessment, nutrition, physical activity, weight management, treatment and rehab for side effects, family and caregiver respite, program offerings, and self-advocacy skills. And then, so I was able to, I would say that there are survivorship plans that are out there. This is from the Foundation from Women's Cancer that I'm going to click on. It's, I think if you are on that website at all, it's through SGO, and this is, let's see if I can you guys see it? I don't know if you can see.
Yes, we can see
it.
Okay,
good.
Also,
okay.
The Foundation for Women's Cancer is listed on the resources of the survivor.org website, but we'll also grab this link and specifically share it too. Emily, capture that for our notes. Thanks.
And I can send it later too. So this just goes through the survivorship pan, histology, pathology, genetics testing, total treatment summary. It's a pretty open document, but I think it's good to have that document. And then follow-up care for cervical cancer by Cervivor there. And I like the fact that it gives you kind of intervals. It shows you kind of intervals for surveillance visits and recommending screening tests. So let's see, how can I go back? Okay, so, and then I think that's pretty much it, but I'm just gonna tell you, I am not good with survivorship plans. And the shortcomings are, I think, in terms of the provider, from a provider standpoint, we're helping to diagnose, we're helping to treat. I think when we get to the survivorship, I'm very good at surveillance, but I think in terms of following the whole person, not as good. So it becomes, quote, less of a priority in terms of the survivorship phase. And so that's why I think it's very important that we talk about it, and that you are an advocate, not just for yourself, but anybody behind you or your sister or, you know, whoever, in terms of, I think, advocacy in terms of your health, overall health anyway. The other shortcoming is the lack of adherence. So that goes back to like, adherence to evidence-based guidelines. So you have providers who may not follow. I see people who do, let's say, for example, a patient who has a ovarian cancer, they're doing pap smears on them when it's totally not indicated. So there's some adaptation in terms of following that's not done. And then other shortcoming is the unacknowledged financial toxicity that goes along with cancer care and survivorship as well. So I think that's the last slide. I'm not sure where we are on time, but I'm ready for discussion.